Well, great. Well, it's always wonderful to be here at this conference. It's a great conference, and certainly both David and Dick do an amazing job really pulling this together. There's a tremendous amount of work on their behalf to pull this together. So thank you both. I think it's wonderful for the community, and certainly it's always a tremendous pleasure to be here as faculty and get a chance to reconnect with many old friends. So clearly you've had a very kind of information dense series of talks with a tremendous amount of information. Some of you are almost PhD-like in your MPN knowledge, and others, this may be your first such foray into a conference like this, and might be a little bit overwhelmed at this point. Certainly worry not. It's a lot of information, but again, a lot of time, especially in the breakout groups, to be able to ask questions and help to unpack all of that information a little bit. So I, like my wonderful friends and colleagues in this community, have been deeply engaged in trying to find better treatments for MPN patients. And as a parallel part to that, patients along the way clearly had impressed upon me that they have many disease-associated symptoms, that these aren't necessarily very obvious in terms of external cues for others. Our choices around treatments have a tie-in with how you feel, and on that basis, we begun a whole variety of efforts to try to better understand MPN symptoms, how they potentially impact our choice of therapy, and as I'll share with you a little bit as well, trying to think outside of the box in terms of what other ways can we try to help alleviate some of these symptoms. So first, what is the burden of having an MPN? As Dick mentioned, I now act as a cancer center director, so my responsibility extends across the entirety of all sorts of diseases that range from those that are very life-threatening to those that have a very long course, that individuals might live their normal lifespan but can have some implications. So things on that nature can range for some individuals with MPNs, others with low-grade hematologic diseases, skin cancers, to those that have very advanced diseases. So I've given a lot of reflection to, as we try to assess the burden of disease, how do we really think about it? In MPNs, all of you are afflicted potentially in different ways. And there are different burdens that we might attribute to an MPN. Risk of vascular events, impact in terms of the blood counts, are they too high, are they too low? The risk of progression, which I know from our own studies is foremost on many of your minds. The issue of the spleen, is it an issue, is it not an issue for you? The impact of symptoms, and then, of course, none of you are an MPN. You're individuals with complex medical history, whether it's no other medical problems to multiple medical problems. And all of this exists, of course, in the context of your life that has many other factors well beyond your health. So as you deal with a chronic illness, clearly all of these things come into play. Now, within MPN, there are many things that we have studied that I think are insightful. The first is that there are many ways that a chronic disease like this can impact you, even when we don't view it as life-threatening. And one of those can be in the area of employment. In this study, which we published just earlier this year, again, we see that based on decisions to retire early, issues of fatigue, issues of modifying work schedule, MPNs can have an impact on employment, and frequently the most common, I would say, is it modifies people's employment status. But certainly there are some that have been medically disabled due to the difficulties from the disease. And that itself has its own financial strain. Now, we did a study that we recently published, again, asking physicians and patients what are their goals regarding treatment. And it was interesting because we wanted to compare, because particularly with a chronic disease, what our goals are quite important as we make decisions together regarding your treatment. As we ask patients, it's clear that their number one goal is trying to prevent, from physicians, it's clearly trying to prevent blood clots and bleeding. Indeed, as you've heard much in the way of treatment and treatment summaries, both today as well as from your doctors, most of the treatment decisions in PV and ET have really been focused on trying to prevent blood clots or bleeding. It's actually been individuals such as Dr. Silver that really have been pioneers of trying to have the concept that in PV we hold as a goal to try to prevent progression of the disease. Clearly, as we look in patients, this is one of the biggest areas of disconnect. For patients, slowing progression of the disease is a very important goal. For physicians, it's less on the radar at the current time. Now, part of this might be a little bit of a reflection that they don't necessarily feel that they have the tools to avoid progression. This disconnect was similarly the case for polycythemia vera and in myelofibrosis. And interesting, in myelofibrosis, perhaps even due to some of the efforts of my group, the issue and a need for symptom improvement is now very much on the mindset of treating physicians. However, our patients with myelofibrosis clearly tell us that slowing progression of the disease is a primary goal. I don't think that that means that these individuals want to feel any worse. I think people want symptom improvement, but clearly they are very concerned about progression of the disease. We similarly did a study in Europe and other countries around the world and found a similar sort of feedback. So again, I think even attendance at a conference like this is really regarding a thirst for knowledge and a desire that the science advance to try to prevent progression in these diseases. Now, what about symptoms? These are diseases that have potentially many symptoms. And as I'll share with you, these symptoms are real. They have biochemical basis. They can give us insight into sometimes the behavior of the disease. And really, the study of symptoms has really been a partnership between the patient community and us as investigators. And even the initiation of this discussion really is owed to patients who have been profound advocates for MPN patients. Individuals such as Joyce Niblack, who was one of my patients, as well as many others who strongly advocated, 20, 30 years ago, that these were diseases that afflicted people in significant ways, sometimes even though you don't have an external cue regarding the symptom. Now, we work really as a team-based effort with all of the investigators here and many around the world to try to quantify, develop tools that could quantify symptoms and carry that out to the rest of the world. And with that, we developed a series of questionnaires that looked at quality of life, fatigue, spleen-related symptoms, and constitutional symptoms. We then added symptoms related to vascular events or mood and created further instruments. We now have data in over 5,000 patients in 45 different countries. And I need to update this slide. We have it in 27 different languages, including Urdu. And with this, I could tell you that the experience of a patient who is a female with an MPN in Uruguay versus Ulaanbaatar in Mongolia, versus New Zealand, might in fact be really quite similar. Now, this is just an example showing in written form. These are the 10 core items. This is in both English and Arabic, where individuals can find and track these symptoms. Now, most of you have said, boy, I haven't filled out many of these sorts of forms. Part of that is working it into the workflow of a busy clinic. And folks such as myself, Dr. Galib, and others, we work with the companies developing electronic medical records. So in the future, you'd anticipate that before you see your doctor, and this may be the case already, you may fill out a series of questions on your tablet or phone, etc., before you go in, so that these issues can be tracked. And they may not only be limited to MPN symptoms, but as healthcare is evolving, also might include issues such as pain, distress, or other difficulties. Now, these symptoms are both common and they are not limited to myelofibrosis. Myelofibrosis patients overall are the most symptomatic, then patients with polycythemia vera, then essential thrombocythemia. But these are as a group. There are individuals with ET that might be more symptomatic than some individuals with myelofibrosis. So like any of these things, they can overlap. We have learned that all the symptoms are not necessarily the same. Some symptoms are very common. Fatigue is almost universal. Whereas other symptoms such as fever are rare, but when they occur might be a sign of progression. So I view symptoms such as fever, inadvertent weight loss, which all of us know just does not happen without trying for most of us, or bone pain as a little different than symptoms such as pruritus or itching. Now, people have criticized, or raised the concern, people are saying they're fatigued, they have these symptoms. I'm not buying it. I have to take my daughter to harp lessons. I got to take my son to soccer. I got to go early to work. I got to come back late from work. I got to go back at night and pay my bills. I'm fatigued. My patients are complaining they're fatigued. Cry me a river. We're all fatigued. Suck it up. So we collaborated with some colleagues from Ireland, and they did a study of people in Dublin as age-matched controls for MPN patients, and clearly showed that MPN patients were quite a bit more symptomatic than the general public. Now, symptoms and quality of life. This is a frequently confused set of concepts. Quality of life is an aggregate concept that includes, first, as we speak about health-related quality of life, overall quality of life might be poor because of any external event. Death in the family, loss of a job, whatever. There's many things that can impact quality of life. Health-related quality of life, again, are related to efforts really with your health. So again, as issues like phlebotomy. Well, if phlebotomy, it sounds like it's not a big deal. And for some, perhaps it isn't. But if they have to stick you 4 times, if you have to go back in, if you are dizzy after you get the phlebotomy, if they only got off 200 cc's today, and you got to go back tomorrow to get 250 more cc's taken off, now 2 days of your life have been spent wasted trying to deal with a phlebotomy, that's a big impact of quality of life. So quality of life is an aggregate of symptoms. If you're on a medicine and it helps one symptom, but it gives you diarrhea, you have to go every hour, that could be a big negative. So what is the cumulative impact is quality of life. Now people have asked, well, you study symptoms, how symptomatic does one have to be to start a treatment solely on the basis of their symptoms? And that is always a judgment call. The decision on starting a medicine or adjusting a medicine is a discussion between you and your physician. Now what we can say is by thresholds, that individual symptoms that are greater than 5 out of 10 or a total score of 20 out of 100 are statistical outliers that this is a strong consideration. We also see that individuals that have these symptoms we can tie to clear biological differences in the disease in terms of their counts, spleen size, risk scores, etc. This is similarly true for patients with ET and P. vera. Now, people have asked, and this font is small, and certainly I'll have these slides available to David, and certainly are fully in the public domain for any of you to be able to review on your own, is that symptoms are not necessarily related to risk. We've heard discussion of risk throughout the day. Risk regarding developing a blood clot or bleeding, or risk even in terms of a disease being life-threatening. The symptom burden can have a link to risk, but they are not superimposable. There are some individuals that may never have a blood clot, but still have a lot of symptoms, and vice versa. Now, we've learned some interesting things by studying MPN symptoms. One, the diseases are very heterogeneous. And again, as we look in a colored format, we could see overlap of different clusters of symptoms between patients with ET, PV, and MF. We also see that there is an impact on the duration of the disease. The longer an individual has an MPN, the more symptomatic they are likely to become. We see that there's an impact on gender. And although I risk poking any humor at this part at all, I'll just leave that part out, but say that we clearly see, and this is independent of culture, that women are more symptomatic and that there are specific symptoms that they're tied to, and there may well be issues related to estrogen or other things that are associated with that. There clearly is a significant impact on insomnia. Now, some of these things are at the beginning of being studied, but of course are logical. I mean, if you're having iron deficiency, restless leg, night sweats, and it's uncomfortable for you to lay on your side because of your spleen, it doesn't take a rocket scientist to figure out that that's interfering with your sleep. In that same category of rocket science is the issue of intimacy. So again, I've had some folks say, well, I've got night sweats, I'm itchy, I got the big spleen, I can't lay on my side, I'm not feeling really sexy tonight. But by the same token, I have found that when therapies are very effective, this is first the second most common difficulty in these 5,000 patients that we have studied, culturally independent. Now, it might be a bit more intense the closer one gets to the Mediterranean, and might be a little less complained about in Scandinavia, but still is the second highest. And if people are feeling quite a bit better, this part of life, which is an important part of life and a frequent barometer of quality of life, resumes its more natural state in an individual's life. Now, what about biology? I mentioned to you these symptoms are important, but they're not random. These aren't just things that you happen to get. There is biology. Now, people have asked, well, are these symptoms because people are distressed? I don't know what the future holds. Or is it because of the biology of the disease? The truth is there's probably some of both. So we did a study, and another very active, wonderful advocate, and my thoughts go out to him, Zen, really pushed us in this regard. And he said, a lot of patients are complaining about fatigue and other things, and he, as a very astute patient advocate, raised the issue, are they really depressed? There's distress. We're telling you we don't know what the future holds. You'll see 6 of us give a talk, and we'll all give slightly different views of the same thing. All of this causes distress. I watched The View. Nobody ever talks about an MPN. I watched General Hospital. There was actually a PV patient. But other than that, most people don't really have a way to kind of connect with this. So we did a study. Some of you might have participated. And we had results of 1,800 patients with MPNs. And what we identified is, yes, individuals with MPNs do have higher rates than the general population of depression, anxiety, stress, and grief. And that if you have uncontrolled issues of mood, there's one thing to be distressed, and for some it can cross over to where it's a problem. And if it's a problem, it might taint other things in terms of how you feel, and it certainly can impact symptoms. So I said part can be related to distress or uncertainty, but part is biology. This is a slide where just suffice it to say red means high, and what this is measuring are cytokines, proteins in the blood associated with inflammation, fatigue, and others that are elevated in patients with myelofibrosis. Now, what we have found through these cytokines that are signaling molecules in the bloodstream is many of them are increased, and they may be tied to things such as the spleen, symptoms, disease advancement, or even advancement of the disease. So again, the issue of inflammation, cytokines, MPNs, is a parallel part with the mutational analysis that has been seen. And indeed, the sequelae of inflammation may have a variety of implications in this disease. And it's been speculated that the mechanism of action of many of the drugs that we have are at least in part related to some of these properties. Ruxolitinib, clearly, other JAK inhibition, etc. Now, why do MPNs progress? Well, this is a key part, but it relates to this. Is it related solely from clonal progression? You heard a lot around mutations. Do people acquire more and more mutations? We are concerned that that is part. Or is it related to changes in the bone marrow that are conducive for individuals developing additional mutations? And that the issue of inflammation may be linked in part to this risk of progression. Now, where do symptoms fit with management? Well, many of us have been involved with developing US-based guidelines for the treatment of MPNs. And many of these first started with clinical trials, and now the issue of symptoms have become an important part in measuring clinical trials and their effectiveness. Indeed, the FDA now looks at the MPNs as really a model state of diseases where the issue of clinical benefit and symptom assessment was front and center in terms of drug development. We developed these NCCN guidelines, and I won't go through them. That would be its own talk in and of itself. But what I will share is that as we try to provide guidance to physicians in the US, we incorporate symptoms and symptom assessment as part of the assessment in terms of starting therapy as well as adjusting therapies. Now, symptoms are not the only thing by any means, but they need to be considered in parallel with changes in blood counts, changes in spleen, as well as clearly your input, your goals, etc. So this showing an impact in terms of how we manage low-risk myelofibrosis, and a consideration of symptomatic disease may indicate a need for therapy. It includes how we triage individuals who we are managing with essential thrombocythemia in low risk, intermediate risk, or high risk, as well as those with low risk and higher risk polycythemia vera. So these are complex algorithms really derived for providers and not necessarily to overly interpret kind of from a patient's perspective, but it really calls on physicians to weave together all of the clinical evidence in front of them, how you're feeling, your symptoms, along with these other key parts. So in the final few minutes I have, where do we move in the future? So one, my colleague Dr. Gottlieb did a lovely job describing many of the areas of research trying to find new therapies. And indeed, we are all engaged in parallel trying to look at different angles and perspectives, JAK inhibitors, expanded use of interferons, new interferons, new molecules to try to have an impact on the disease. Now, my group has, as a parallel interest, trying to ask the question, what else in addition to medicines can we do to help with symptoms? So we spent the better part of the last decade clearly identifying the symptoms are there, they're real, they have a biological link, and they matter. So our challenge now is, okay, well now what do we do about it? Clearly if we improve therapies, that's great. But what else can we do? So one, our group has been very involved with the analysis of yoga as one mechanism. We partnered with an online yoga company, yoga instruction company called Udaya, to develop a series of modules to be used at home, developed specifically for MPN patients. So mind you, this is the first disease that any disease-specific yoga has been developed. We tested it in an initial cohort that some of you may have participated in that has already been published. This is the first time these data for the larger study are being shown publicly and will be presented at the American Society of Hematology. And the goals of this were, one, to investigate the activity, and two, to try to remotely from home being able to track biological markers of the disease. So it was a 12-week study. Individuals were randomized between 12 weeks of online streamed yoga at home versus a waitlist control who would wait, and then they would get the yoga. We'd just follow them, and then they would be able to do the yoga after the first group was complete. We were measuring symptoms. We were drawing blood tests, looking at markers of inflammation. With this is in a very small font. Over 260 patients were assessed for eligibility. We have learned much during this process, including even how to effectively organize and run large-scale trials like this in a remote sort of setting, being done over the internet, what best things to screen for. There is very little foundation for some of these efforts, so it is a learning curve. Most of the studies done with things like this have been done exclusively in patients with breast cancer, up to this point in time, breast cancer survivors in face-to-face studies. So several new things as we try to really expand this, being able to be done remotely for populations that are more scattered, as well as having them be feasible. We first assess participation Part of this study, there is a way that we're able to track the time individuals are actually on the site versus what they self-report in terms of the yoga, and see that there's overall pretty good correlation, but like most things, people probably fudge a little bit how much time they're actually doing the yoga versus what they're doing, but showing pretty good for our feasibility study. In terms of our major findings, we found that there was statistically significant improvements in validated depression measures in the yoga group. We were able to show that it's feasible to do such a study and be able to obtain concurrent blood draws. We were able to show significant reductions in the key inflammatory marker of TNF-alpha in the yoga group compared to controls. This is just a little bit of the granular data showing the differences between the groups with the strongest correlation in depression. And then here again, we see differences that are favorable in terms of anxiety, pain intensity, depression, sleep. Some of the others more similar. Some of them we may not have large enough numbers. And as I say, all of this is very much of a learning curve. Learning curve in many ways. We realize, one, as we start something like this, we exclude people that are already active yoga folks or who do a significant amount of physical activity to start with. But clearly, how do we, one, increase people that have really never done anything like this before? And so how does one really take someone who's never done something like this and kind of get them on board with something that they can do at home versus someone that already has some baseline level of fitness? So many different parts. Other parallel efforts that are ongoing. There is a cognitive study that is ongoing with a face-to-face intervention at Mayo, Arizona, with my team, looking at a cognitive intervention called ACT therapy. So not everything requires the use of spandex, as well as an anti-inflammatory study. So this in combination with my colleague Robin Sherber, who will be joining me in San Antonio, as well as Angela Fleischman at UC Irvine, that even has murine models of nutrition interventions for MPNs, looking at, again, if inflammation is a part of this disease. Every patient asks me, should I be eating something different? The answer up to this point is we don't know, but truly no one has really studied it. So I'd conclude by saying that the burden is multifactorial and symptoms are a common component. Symptoms in MPNs have a root in the biology of the disease and do change. Serial assessment is relevant not only for clinical trials, but for management. And we do hope to be able to empower a range, once we have fully vetted them, of non-pharmacologic interventions for people to be able to make use of them. And with that, I would like to thank my group. Again, it's a collaborative effort. The current time between my new center, my colleagues at Mayo Clinic that still remain close friends and collaborators, Arizona State University and UC Irvine. Thank you.